Okay, great. Thanks everyone. If you've just joined us, thank you so much for attending our MiCHWA webinar today. I'd like to thank our special guest, Lynn Weber, for joining us. He's going to give you a brief introduction to who he is and what he does. I would like to remind everyone that this webinar is going to be recorded. We'll be sharing a link in the chat at the end of the webinar and also sending out an email to all registered participants so that you can click a link to fill out a survey in order to get your certificate of attendance. If you have any questions, please enter them in the chat during the presentation, and I would be happy to ask them for you. And once again, please make sure that you are on mute at all times as we are making a recording for the YouTube channel. Without further ado, I would like to pass it over to Lynn Weber. Thank you so much for joining us today, Lynn.
Yeah, thank you, Portia. I'm pretty thrilled that we got this many folks, as Portia said earlier, on such a beautiful day. Why are we out? Why are we glued to a screen? So anyway, again, my name's Lynn Weber. I'm a paramedic, a community paramedic, and I'm with. Was I muted, Portia?
Yes, I'm sorry. Go ahead.
Okay, am I muted? Can you hear me?
I can hear you, yes.
Okay, cool. Because all of a sudden I got this across my screen, you are muted, and I'm going, whoa. So anyway, well, I will apologize in advance to all those attending today. Thank you, one, for being here. And the other one is, while I've spent plenty of time teaching and presenting, this is my first crack at the virtual world. I much prefer the face-to-face, seeing all of you in 3 dimensions versus 1. So again, back to where we started. My name's Lynn Weber. I'm a paramedic and a community paramedic. And I'm based out of Clinton Area Ambulance Service, which is in St. John's, Michigan, so just north of Lansing. So some of you may be familiar with this part of the world, some may not. I'm actually fairly familiar with your line of work, basically in partnerships, in the partnership we had with our community paramedic program and our area CHWs. So anyway, so we'll kind of move on. So first of all, there we go. What is community paramedicine? So Michigan, we have kind of a different name. So depending where you're at, the overarching name is called Community Integrated Paramedicine. And under that umbrella, there's a couple of different versions of it. At the end of the day, it's paramedics making house calls. So I guess we always make house calls because that's where our patients are, but these are non-emergent calls. These aren't the 911 calls. These are often scheduled visits for, just to help take care of folks in their homes. Again, 2 general types of programs. There's community paramedic programs, which is what we had, and then there's mobile integrated healthcare programs. And to explain them a little bit better, ours is a community paramedic program. This happens to be the unit I drive, and it's called an ECHO unit. And so it's a fully equipped ALS unit. So make it simple, everything that's in an ambulance is in this vehicle with the exception of a cot and a partner. Other than that, it's exactly the same stuff. So that's a requirement of a community paramedic program. And so we do things a little bit different than the other flavor. And I'll show you a little bit about that soon. Typically, the folks we visit, we are typically referrals from primary care docs and PAs, MPs. And then, believe it or not, Adult Protective Services connects with us regularly. The other community partners weigh in this as well. But that's where we get most of our patients from. When it comes to the folks coming out of the doctor's offices, they're typically the more complicated, medically complicated patients, lots of medical issues going on, sometimes some behavioral issues that mix into that. Or they're folks that, are just don't pay attention. They get the direction from the doc, but they really don't follow those directions. So the folks that aren't compliant, those are typically the folks that get referred to us. We also can, in some areas, manage low acuity 911 calls. So an example of that is we saw a lot of this during when COVID was hot and heavy. We called them the worried well. They weren't really well, but they're folks that were COVID positive, not feeling well. And, obviously a lot of folks were not doing well with this disease. And there was a lot of folks getting very sick and dying from it, that they'd be pretty concerned that they were one of those folks. So we would we would take those calls, do a good assessment on the patient, assure them that, yeah, while you feel really crummy right now, you are not down the path to a ventilator and that you're going to be okay. So we can manage some of those things and we actually treat them at home. Want to make sure y'all understand that everything we do, whether it's with our version or the other version, it's always under the direction of a physician. So we're not, community paramedics are not the cowboys taming the Wild West and doing as we please. While we have a lot of autonomy, we very much are still under and work directly with the direction of a physician of some sort. The other version is called mobile integrated healthcare. And these folks are connected to basically hospitals and healthcare systems. And what they have a problem with, especially the bigger ones, is say they've got somebody in the hospital that's they've had as an inpatient with congestive heart failure or COPD, those kinds of things. When they discharge them to go home, if those patients are readmitted for a similar diagnosis within a certain amount of time, one is the patient's not very happy about it, but the other one is the hospital gets penalized. And I don't know how many of you have ever been in this situation, whether it's in an ED, having been in the hospital, or maybe even at your doctor's office, you get this whole litany of things that they, are part of what you need to do once you leave. And those can be challenging to understand, to really get your arms around and to really comply with. And so what they found is with these mobile integrated healthcare paramedics, sending them to these folks' homes and getting them to make sure that they understand their discharge instructions, that they're complying with those instructions. And like I said, they can, they're going to monitor why that patient was in. Is it weight gain from congestive heart failure from poor diet? What might it be? Is it wound care post-surgery? But they're tasked with pretty specific tasks when they visit these patients, where in community paramedics, we kind of flock shoot a little bit more. We're kind of taking care of the entire patient. These folks, while we respond in the echo unit with all the stuff, they're typically going to show up in a vehicle, probably nothing like what we have, and they're going to have what they need to take care of that patient. So whether it's wound care supplies, maybe it's a cardiac monitor, maybe it's point of care labs, those kinds of things. So it's very specific to that patient and to the population that hospital is trying to take care of. They also operate under the direction of their program's medical director. So again, there's oversight to what we do. What kind of things can a community paramedic or community integrated paramedic program do? The classic line in our world is whatever you need it to. And actually the pandemic kind of proved that. A paramedic's education, a regular paramedic's education is pretty broad. It's only so deep, but there's a lot of things. There's pharmacology, cardiology, the chronic care, pathophysiology, all those kinds of different things that they're trained to do, and techniques and ways to treat people. Well, when the pandemic hit and all of a sudden resources weren't enough to take care of all the folks that needed care, we got, I guess, dragged into the fray, and it worked easily for us because we were, not only did we have the skill set, the equipment, but we're mobile. And so I think that more folks have a little better feel of, what we can do now. And it's pretty much almost whatever you need us to. To put a little bit of history in our community paramedic program, we were one of the first 13 special studies is what they called it. And the state put these in place about 2015. And what they did is they sent us out to try to figure out if we're going to have a community paramedic program, what kind of things do we need to be able to do? And so we have two rules. One is don't break the law and stay within your scope of practice. And it's really all there was to it. And so that fit perfectly into the whatever you need us to do. We now have 64 pages of protocols and things are very specific, but in the beginning, it really truly wasn't that way. In our case, and most of us, we started with a community needs assessment. And basically we were looking for what health issues are a problem where we live. What are the resources that we have in good supply, and what folks, what things don't we have? Here's some of the issues that when we started going through all of ours, we had an idea of what we thought our primary problems would be. We found out through the community needs assessment, we really weren't very close. I'm kind of a lifer. I've been in this community my whole life, thought I was very well versed in what was here and not here, and found out that I wasn't nearly as smart as I thought I was. So anyway, once those problems and those gaps were determined, our job was just to see what could we do to fill those gaps. And that worked out really, really well. The next step, and we found out, we didn't know this going in, but we soon found out that when we got into someone's home to take care of them, we could take care of that medical side, but there was a lot of things we couldn't do. Well, thankfully in our world, the community health worker group out of our Pathways program, which was connected to our health department, they were in place before we were. And it didn't take long. Our go-to person, her name was Shelley, and she was a rock star. And we could fix that little window, that little piece that fit our realm and our training. But she really helped us round out the care we could provide to our patients. And so we ended up with a very, very solid program with some phenomenal results. One of the stories I'll share at the end of this, that it's a struggle for me to get through, but it's a tremendous success story, but it has a lot to do with our partnerships with the CHWs. So kind of comparing a community paramedic role versus the community health worker roles, do a little bit of that. So our training is, in most cases, most of our paramedics, their background is totally medical. Their background, their education, their experiences are very focused in that part of the world. Good at things that involve pharmacology. So managing people's medications is just something that's okay for us. Cardiology, good chronic disease management, all those things we're pretty good at. We're good at assessing patients. Community paramedics go through a more enhanced program to do even a more thorough assessment than what we would do on a normal 911 call. Lots of different things. Problem solving is a lot of what we do. We could run 3 chest pain calls today, and they all might be very, very different in how we manage them, because the situation could be different. The actual symptoms could vary. The environment could be quite different. There's just a lot of things. So we actually have to weed through, ask the questions, do the evaluations. And so we're always trying to fine tune and make sure we get to the root cause of the problem so we address it appropriately. So problem solving is a big thing in what we do. And the other one is really, really good interpersonal skills. Those folks in that house, whether it's the patient, the caregivers, family, whatever, need to trust us. They need to know that we're there to take good care of them. And we need to be able to communicate with them on whatever level they are. You know, some folks are able to communicate at a high level. They're well versed in their medical condition. You know, they're pretty good to go. And the next one, not so much. And so those are some of the things that we really, really, really need to be good at. And another one we need to do is we need to be an educator, and especially in the community paramedicine side of things, because these folks often aren't well versed in what their condition is, and they need help understanding it. The doc will tell them, or the NP or the PA will talk to them about it, but there's a lot of folks out there with white coat syndrome. The brain doesn't really absorb much when they're in front of that white coat, and so it's just not necessarily a good learning environment for them. So let's compare that to the community health worker. So you folks come to the table with a lot of different backgrounds along with your community health worker education training. And so with the different backgrounds, experiences, those types of things, we found that to be of huge value in our program. With, like I said, well, we were pretty good at the medical side. Shelley, our CHW, and actually we had a couple of them, but she was our main go-to. She was well-versed in a lot of other things that we weren't tuned into. As an example, in our 911 response area, we have a very, very, very tiny homeless population. In fact, they're probably more couch surfers than I would call them homeless. But our community paramedic programs serve the whole county. And in the other end of the county, they do have a homeless population. We were not well equipped to try to figure out how do we address the big picture for those folks. Shelley stepped up. She was phenomenal at that. And so what we found is what the backgrounds that in the education experiences that they brought to the table, coupled with ours, really eliminated a lot of the gaps we needed to take good care of our clients, patients, customers, whatever you care to call them. You guys are so well versed in community resources. Again, like I said, I've lived in this community for my entire life. I had no idea what there really was available. and shame on me, but we got educated by the community health worker. So when we ran into a patient needing that type of, something beyond the medical side of it, Shelley was our first call, or her partner in crime. And it worked out very, very well. You guys are problem solvers as well. You run into a lot of similar problems with different environments, different cases, and you just got to sift through that and come up with a solution that's going to fit for that particular person. Same way, those folks have got to trust you like they have to trust us. And that's the skill set that's paramount in both of our lines of work. And I know you folks do a lot of educating too. And again, I will share that my knowledge of what you all do is very much related to our relationship with the folks here. But I can't help but think that probably most of these are shared amongst all of you out there. So who's our customer? Who's the folks we're taking care of? In our case, probably your case, many, but not all of them are elderly. A lot of them don't have a lot of extra money. They're living on fixed income. So any little hiccup in the plan puts them in a really, really bad spot. A big one for us is they do not want to go to a nursing home. Whatever it takes, they will fight tooth and nail. And in a lot of cases, there isn't much keeping them out of the nursing home. They have issues with activities of daily living. They have, chronic or fragile health. Medications are a scary thing for a lot of people. Can't tell you how many of our patients look at those medicines. I don't know. The doc told me to take it. I take it. They don't even know what it's for. We run into issues where we have multiple prescribers. So they have a specialist and maybe their primary care, and they don't know what each other's doing. Unfortunately, that's not supposed to happen, but it does. And so we run into some really not good interactions. We've had patients given wrong medications. Where the error was, we don't know, but when we're filling the pill boxes, we go, well, no, this isn't going to work. And so we've caught a couple of those. People tend to also decide how they want to take their medicines, and I think that'll come up here a little bit later. So that's its own little issue. But these folks all want to remain independent, but they just need some help. And again, that's where your role and our role works in hand, because they need help. All of them are a little bit different. They need different kinds of help. But between the two of us, we manage things pretty well. The key thing, and this is again probably more your role, but we rely on a lot of you folks, and we get a little better at navigating and resources in the community, those types of things, getting folks, connecting the dots so folks can be successful. Probably in yours like ours, a lot of them have folks in the picture that want to help, but they're either not equipped, either emotionally, mentally, or physically to help, or they're not available. Their work schedule doesn't allow it. Some folks just flat don't have anybody. So the things that you can do and we can do can still allow these folks to be safe and do okay in their own home. So what are some of the services that a community paramedic program might offer? We do a ton of med reconciliation. Filling pill boxes can be very enlightening. It's amazing how many folks have their own ideas of how to fill that pill box. We've had folks that, they're struggling with a congestive heart failure. They're still retaining way too much water. When we're there and we're actually handling the pills and we look and they've got like an 8-month supply of their water pill still on the shelf, we start asking, I go, are you taking these the way you're supposed to? And they tell the doc they do. When we get there and we're seeing this boatload of pills, they understand that, well, gig's up, we know. And so they'll share with us that, well, he's got me taking this before bed and I get up 3 times in the night to go to the bathroom and that just doesn't work. I can't get any sleep. So we can work with the doc and say, doc, let's change the regimen a little bit and get them back so they're getting the appropriate amount of medication on board, and or changing meds, whatever the case is, but allowing them to not self-medicate and make rules up because of either the way it affects their body. And it's amazing how many don't take medicines because their friends said they had a problem. That's again always a struggle. So we can us getting there, filling the pill boxes, monitoring how they're taking them, can make a huge difference in their quality of life and how well their chronic condition is controlled. We monitor their vital signs, those types of things. In a lot of cases, we get the equipment with your help, but we'll get them so they can monitor their own blood pressure, their own blood sugars, weights, those kinds of things, and we just have them put it on a log. And then we simply monitor the log on a weekly or bi-weekly visit. And, it's entertaining, when you go through that. And, we encourage them to be honest. And I'll look at somebody's blood sugars and they're running pretty good. And then there's a spike in one. And I go, okay, what happened here? And they get sheepish and they say, well, my granddaughter's birthday and I had a piece of cake. And I go, well, good for you. Just don't eat the whole cake. Have a piece of cake, celebrate. Don't take away from your quality or your participation in life. But just, it encourages them to be comfortable being honest with the readings. And that allows us to track any trends, or do we need to make a change or recommend a change through the doc to maybe change the dosage on a blood pressure med or a diabetes med, COPD med, whatever the case it might be. Telemedicine visits are, obviously there's a lot of folks that's a big thing, especially since COVID came to our world. And but in our part of the world, and maybe in yours, that's not always an easy thing to accomplish. We're in a rural community, and when you go to the country, especially folks on limited income, there's no internet access. They don't have smartphones, so they can't have that telemed visit with their doc or PA or NP. We can take the technology there and allow that to happen. And we can also do procedures and things right while the doc's there. Can you listen to the lungs? We can actually Bluetooth breath sounds into the visit. So I mean, there's a lot of things that we can do, and so that can be very helpful too. Again, assessment-wise, we're pretty good at physical assessments. We're not counselors, we're not those types of things, but we can kind of get the feel for their moods and their affect and just where they're really at. And is there things that we need to connect some dots there as well. We also, to make sure the home's safe and just see where they are in the social determinants of the health scale. What are the things missing that maybe we can help connect them to, so we can kind of limit the effect that would have. Again, we do a ton of education, both patients and caregivers. A lot of them again, COVID and a lot of things that have happened in our world, we're all familiar with the amount of misinformation there is out there. We build that rapport, that relationship with that patient and become trusted. And we can kind of weed through a lot of that. We can get them to understand, and more clearly, their disease process, what they need to do, what's going on in their body, and why they need to do certain things or not do certain things. Lifestyle changes are huge. Some of these folks are having to go against things that they've done their entire life, the habits and things they've done forever. And it's difficult. It's difficult for all of us to to address those things. And so us being there on a regular basis makes that a little bit easier to get those changes, put into effect. Again, community resource navigation. Again, we're blessed to have you guys. So that's our big thing. Is often we're going to be connecting either to RCHWs or Adult Protective Services. And we have a great relationship with them, and those folks are truly our friend. Providers, what kinds of things? Where are we at with those kinds of things? Most of them in our realm are going to be formally trained in community paramedicine. So that's trained in the emotional and behavioral health issues, much more in-depth patient assessments. Maybe not to the level of doc or the MP or PA might provide, but certainly more in depth than that I would perform, for example, on a chest pain call or difficulty breathing call and a 911 call. We're dealing with acute situations where it takes more in-depth evaluations when you're dealing with chronic care patients and problems. The other one is again, this home safety stuff, the social determinants of health. It's the really much more big picture kinds of things. To go back when I first started EMS, back when books were on stone tablets, we really looked at public health and primary care as, they were like, one was Mars and one was Venus, and we were just another planet altogether. And we've since learned that what we do is very, very, very much connected. And we've taken down a lot of those silos. And so we work a ton with public health. That really was helpful when the pandemic showed up. We were already first name basis with everybody, and things flowed very smoothly in our part of the world. But those are the kinds of things that a community paramedic brings to the table that a standard paramedic may or may not be as well versed in. again, the assessments are going to be a lot more involved. Any of the paramedics can do 12 leads. We can transmit them to the doc, those kind of things. Point of care labs are like the iStat and the Piccolos and those kinds of things. Apologize for that because I can't kill that. I'm hoping somebody else will pick it up. There we go. So my apologies. Again, the telemedicine visits with the primary care doc will mostly be done with the community paramedic. So those are the different types of things that we can take to the home. A lot of our folks don't want to leave home, or they have transportation issues, or just a lack of resources for transportation. This really helps fill in the gaps and takes better care of people. And they're not falling through the cracks because of those issues. Some of the things that we do are just things that an EMT or the normally trained paramedic are able to do. And those, in some cases, those will be the providers that you might interact with. Key thing is all of them both are in a position to medically evaluate the patient, see what they're like effectively, where are they at mood-wise and just mentally, where they're at on that day. They can look around, make sure the home's safe to see if there's a need for any sort of assistive devices, and just really kind of get a big picture for it. So any of these folks could be an asset to these folks. And again, we're back to that I guess I'll say that marriage between CHWs and CPs. So kind of the day in the life of a community paramedic. Every call that we go on, whether it's EMS wise or community paramedic wise, most generally we're going to be getting our problem solving skills dusted off, and we're going to work through how to best manage the situation that we're faced with. The key thing with this is that, it's pretty easy if we go to somebody having a heart attack. We know exactly what we need to do. It's protocol driven, and there really isn't even a lot of thought to it. You go to educate somebody about their congestive heart failure, and that's a whole different animal because everybody understands things at a different level. The one advantage we have is we're in the home, we're in their comfort zone. And so they're going to understand, they're going to be more able to absorb the information we have to share because we're in their home. And so in that works the same way with the caregivers. So, but again, it's unbelievable how many times you may have to try to explain a disease process to somebody or why they, not so much the process, but why they need to do certain things or not do certain things. But I can tell you that the conversations had in somebody's living room are totally different than what are had in a doctor's office or in the back of our ambulance. The key thing is we see firsthand what they do or don't understand or can and can't do in their environment. We can, being there is just priceless. The doc's not there. If we pick up that patient out of an urgent care, for example, we don't see the environment that they come from. And once you put all those pieces together, it allows us to take much better care of that person and their condition. And again, it also, back to you guys, keep dragging you into my presentation, I guess we'll say, but partnering with you connects us to all the things that we can need to allow them, again, to do well in their own homes. Assistive devices, resources, again, that's our partnership with you and some of our other partners that we work with, because we're right there. And we see that they're struggling to get to the bathroom. We see that their kitchen is cluttered and that they really are going to need some help, or that they share with us that they, their diet is poor and they live on TV dinners and they can't afford that kind of salt intake. We connect them with community health workers, Meals on Wheels, get good food in there, church groups that have, perhaps fresh produce opportunities. There's just all kinds of things that being there allow us to accomplish that we couldn't do in any other way. So this is my story. I will apologize in advance. This is a very, this story is very near and dear to me, and especially she was one of my community paramedic patients. And just because it was just such a huge success. So kind of here's our story. So we were referred by our Shelley, our community health worker, and I believe she got her referral at the doctor's office. But what we had is an elderly lady. She was late 80s. She had congestive heart failure, diabetes, and was starting the onset of dementia. And she was being cared for by her adopted daughter. Things weren't going particularly well. Well, the reason she was being, her little background here on this situation, her daughter was actually adoptive. I think I got that there, but her daughter was a truck driver that was off on disability. And if you could put in your mind, take away the gender part of this might make it a little bit easier, but I would guess almost as if you're going to stereotype people, a truck driver, there's tattoos everywhere, and this gal could cuss like a sailor. Let me tell you, she was just obviously not really geared to be taking care of an elderly lady, and just not geared to be a caregiver at all. Patient Betty was the sweetest, most typical grandmother you would ever want to meet. Sweet, cooperative, always smiling, always happy, almost always had a cat in her lap, very agreeable, just a wonderful, wonderful lady. The daughter came home when the mother started failing, and so because she was unable to work, was on disability, she agreed that she would stay there and take care of her mom. And she made her mom a promise that she would never put her in a nursing home. And so some of you can probably already see where this could be, why things weren't going well. So you got somebody that's a truck driver, not a caregiver, and then having to try to fulfill this promise that she had made to her mom. Financially, they were in really poor shape. It was paycheck to paycheck. House needed some repairs. I think it was the roof. I remember it was the biggest issue. She was basically housebound because the house wasn't easy to get in and out of. They were struggling keeping the heating bills. They had fuel oil. All the house out in the country used fuel oil. So they were struggling with keeping the fuel tank full. And then she wasn't doing a very good job at all of controlling her water problems or weight gain problems from congestive heart failure. Diabetes wasn't really well controlled, but it was better than a congestive heart failure. That's kind of the story we had. So Kelly went to work. She got him connected, got some people in place, got some help getting the fuel oil tank filled, got some folks in to help repair and support to pay for getting the house repairs done. And she actually connected with Habitat for Humanity, who built this small porch with a ramp connected to it at her back door. So all priceless things to kind of ease the pain that this daughter and mother were going through. Of course, then she got a hold of us, and because we still had the medical issues that were a problem. And so she asked for us to kind of step in and help managing the congestive heart failure issues. And Tuckin was a daughter, Judy was the daughter. And for all the roughness and toughness, and you would think, Judy's persona was one of those kick butt, take names, no fear, don't mess with me. This daughter had significant fear about screwing up the medications and hurting her mom or even killing her mom. She was just deathly afraid of managing those medications. And so that became our role. Was we came in and we would take care of, we would fill boxes every other week. Judy did a great job of making sure that she took her medications and monitoring blood pressure and the weights and the blood sugars and all that stuff. And she did pretty well. Things were really, really good. But it was pretty interesting. And our first visit was extremely memorable because that's when I met Judy, and the more F-bombs in a sentence than I could put in a lifetime. And just the I guess I'll say the roughness, but then the sincere desire to take care of her mom. And she shared with me the reason behind it is that she goes, I was destined to be either dead or in prison by the time I was even in my late teens. She goes, my mom did not have to take me in. And she did. So I'm going to make sure that I uphold her promise and to not put her in a nursing home. She goes, but man, I need help. I need help. I can't do this by myself. And so that really became our role, as working with her. And we visited every other week and worked through a lot of different issues. Why is her water gate not coming down? Why Judy always struggled with getting her to eat. And so we moved forward with that and found out that when she finally got her something that she liked to eat, it was her TV dinner. Well, her favorite TV dinner, she'd eat 2 or 3 a day, eating good, right? Well, each one of them had the daily allotment of salt for this poor lady. So her sodium intake was through the roof. So we worked through the diet issues, lots of different things. But in the end of the day, we managed to keep this lady at home and do in relatively healthy. So kind of at the, as things progress, we'd go see her, she'd be sitting on that porch, watching the sunset, cat in her lap, happy as a clam, a little more demented than she was, but just phenomenally healthy. The daughter wasn't on the verge of self-destruction because she wasn't able to manage it. And at the end of the day, we moved forward with allowing this lady, this daughter, to keep her promise. Mom did end up dying at home. We got there, when we got that call, we got there, a lot of very sincere tears and hugs and those kinds of things. But it was the combination of what Shelley and her role as a community health worker and us in our role as community paramedics, the things we were able to do for this family. And a phenomenal experience. I just can't even begin to share just how amazing that truly was. So kind of as just as a kind of a summary of where things are, where we're going. Key thing to remember is the things that you guys do every day make a huge difference. This is just one of the stories. I'm sure you all have your own stories that go with this. And it's a reason to keep on keeping on. I know it's been tough especially through COVID, doing what you do. And I know that, I'm sure your pay is like a lot of my guys, not really what you think it could be for the importance of the difference you make in people's lives, but really understand that the things that you all do every day make a difference. And the things that we can do together certainly do as well. Again, this is, if you count you as two and we as two, our 2 + 2 makes 6. We are just that much better together. Most of the folks we take care of, they just need that little bit of help, and things you can do, things we can do, can get them so that they have a quality of life that they couldn't have understood or experienced otherwise. And most of them are capable. They just have the little pieces and parts and the knowledge, the resources, whatever it takes to get this all put in place and so that they can be successful and live at home. So both of our roles require creativity, critical thinking, problem solving skills, and just a desire to genuinely make a difference in folks' life. So I think you guys are really good at it. I think my guys and gals are really good at it. So I certainly appreciate all of you do. So with that, if there's any questions, I'm happy to entertain them. I don't know, Portia, if you got any. If not, then my contact information is here, whether you go through Portia, go direct with me. Any of that stuff is good on my end. So thank you for your time.
Thank you so much, Lynn. We do have some questions. The first is from Stacy Eland from Troy, Michigan. Her question is, how can a physician's office look into the possibility of aligning with a CIP network?
Well, first of all, you got to figure out, we are not statewide. Like in our case, we serve Clinton County. In your area, I would imagine MedStar is in Stacy. I don't know if she can know if that's the case or not. But there's MedStar, and then it's called Emergent Healthcare Partners. And so the key is one is the physicians may not know at all about the programs, but in that general area, those two agencies both offer a type of program that might accommodate that. So Emergent Healthcare Partners and MedStar, but it's connecting with that agency that works in that area. I wish I could speak to for sure Troy's covered by one of them. I'm not 100% sure.
Okay, great. Thank you for that. Our next question is from Valerie Gomer. She says, does the paramedic perform the social determinants of health assessment?
They do, Ken. We don't have time for the history of ours. Our program is currently not in operation. COVID was a big part of that and some complications. But anyway, the really defining that and making that a regular part of all of our assessments was not as robust as it could have been, should have been. The new era of community paramedicine, we're actually working on getting ours back on track again. That's just going to be part of one of the initial questions that get answered on the initial visit. So, but yes, typically yes. In the past, it was so-so.
Okay, great. Before I go to the next question, we actually had a comment in regards to the first question from Dwight Hughes at WWCSD, who says, MedStar only serves PACE participants. EHP does not have MIH/CP services in Troy,
Okay.
if that is helpful.
Yeah. Yeah, the PACE is a neat program, but again, that's yeah, that's again, our counties, our folks don't have that opportunity now either. So
Okay, great. Moving on. The next question is from Victoria, and she asks, are CIPs able to refer to other agencies or services if needed?
absolutely. Again, we spent a lot of our time, our CHW was go-to. That's just the way it was. But yeah, we can, whether, we can make direct contacts with these organizations too. Every case was a little bit different depending on the needs. Some were very specific. We could go get, if somebody needed a walker, we didn't have to involve our CHW for that small part. But there's a bunch of things in play. But yeah, we can refer to our Meals on Wheels. We can refer and help the primary care have them connect to others. So we can't perform referrals the same way a physician can. So if that's what they're meaning, if it's to a specialist, we would go back to the primary care for that, if that was the point of that question.
Okay, great. Thank you. I don't see any other questions in the chat. I'm going to share the link to access the webinar survey. Oh, we have one more question. This one is from Dara Harris. Hi, Dara. So glad you were able to make it. How often do the social determinants of health come into play?
Oh, in our realm, like I said, we seem to walk in a little bit with tunnel vision. And again, I'll preface our program starting before we went into it, kind of ignorant, just having a global view. And so if you get right down and you go back and look at them, we didn't do that assessment on every patient. Going back, those were often the things that, there was one of those social determinants of health, or probably in more cases, multiple, that really made a difference. That we needed to fill those gaps. We needed to address them to get these folks, more independent and be in a spot they needed to be in. I don't know if hopefully that answered that question.
I think it did, because there's no additional question.
Okay.
I would like to thank you so much for joining us today, Lynn. We really learned a lot. We appreciate your time and have a deeper insight into paramedicine and how it links with community health work. I would like to tell everyone that we have shared the link to access the webinar survey in order to print or view your certificate in the chat. So go ahead and click on that, go on over and take the survey. If you're not able to access the chat, please just wait for a couple of minutes. As soon as the webinar ends, I'm going to send out an email to all registered participants. Please keep in mind that if you did not register for this course, that you're not going to get those informational emails or the Zoom link. So please make sure that you do register in advance. And by advance, I mean by 1 minute before the webinar starts. Hopefully sooner. We have, oh yes, Dara said you did answer her question. Thank you very much for the informative information. Lots of other thank yous in the chat. And people think that this was really great information. So I'm so glad that you joined us today. We appreciate your time. And thank you to everyone who joined us on this webinar today. And I hope you all have a great day. See you guys soon.
Thank you all. And thank you all for what you guys do. It's very important.
Bye, everyone. If you'd like to unmute to say goodbye or show your face so you can say goodbye to everyone, please feel free to do that now. Otherwise, thank you very much.
Bye-bye.
Bye, Dara. Bye, Lawantha.
Bye-bye.
Bye, Melissa. Bye, Alexis.
Goodbye, everyone.
Bye-bye.
Hey, there's your car, Portia.
There it is.
Portia, I can't begin to share with you how much I truly respect what your folks do. Again, one of the key parts of the success of our program was really the fact that our community health worker group our pathways program was solid. When we started to do what we were doing, the docs didn't even want to talk to us. What are you doing? Are you serious? Are you, again, it was a foreign thought and idea to our part of the world. And just like somebody mentioned, how do they connect theirs in their area? It's only in some parts, but our partnership with pathways and the CHWs added so much to the success of our program, and it's actually going to give us a lot more traction getting our restarted again. Right now, our biggest issue is financial. It takes a lot. There's a lot more rules and regulations in place. Like I said, 64 pages of protocols compared to 2 one-liner rules when we started. But we actually have got our county talking to us using ARPA funds to help put it back on track, to help us get things started. A lot of these services now we can actually get paid for. I think most of your folks work based on, I'm assuming, grants and some sort of other funding. So
Lots of those are time limited grant awards, unfortunately.
yeah, I know, because I know Shelley worked for peanuts. It was heartbreaking. And she got a chance to use her education and background, kind of a parallel move skill set wise, but certainly a big step up.
Yeah, we're really
income-wise.
trying to get CHW services reimbursable by Medicaid. And once that happens, and licensure or certification becomes mandated by law and recognized by the state, then I think those wages and that sustainability will go up. And we just had our CHW Advocacy Day on Tuesday, which was great. About 50 people were able to go to Lansing and meet with legislators and talk to them about the importance of not only the roles of community health workers, but the benefits that they have to the communities that they serve, and also all the other systems that they integrate and can integrate into to create community linkages. And we're hoping that by talking to legislators that this change in policy will happen soon. We just recently hired a policy analyst at MiCHWA as well. I think she started last week. And so we're really trying to make strides in improving the ability of CHWs to not only get quality employment, but also employment that's sustainable, that's permanent, that's long-term, and not always susceptible to the ending of a grant cycle.
Right. Well, I know that one of the, and I can't speak to it in any detail at all, but community paramedicine, like I said, is very hodgepodge. Like Emerging Healthcare Partners is basically the Jackson, Ann Arbor. It's kind of like Huron County, Jackson County, I think Livingston counties. They work in those, mostly in those 3. I'm kind of surprised that MedStar hasn't moved forward with that, but MedStar, there's a typical company. What's paying is how they operate, and community paramedicine at this point really doesn't pay much of anything. But anyway, back to the story is that the UP is trying to, because obviously healthcare resources are very sparse, very far apart. But I know in cases up there, they were talking about trying to dual purpose, dual license, whatever, community paramedics and community health workers have one person with both credentials. So in this case, the community health worker credential would be an easier one to acquire. A paramedic education, if you take the short class, that wrecks a year, and if you take the long one, it takes pushing 2. And
is it?
Yeah. So there's a lot more. It's going to and then community paramedicine is on top of that. So I would imagine the community health worker training and education is probably more like community paramedicine, where it's not, there's a lot to it. It's not the level of paramedic.
Right. I think it's a good, nice stepping stone, and we're always looking for stackable credentials for our community health workers to add. So I think it's a nice next step for a community health worker. It's a 166-hour foundational course and 8 core competencies, but I think that combined with the experience that they have in the community would prepare them to take that next step into taking a paramedicine course.
Yeah. Well, the 2 gals that we worked with, one was just very briefly, but she was actually an EMT and worked on the ambulance before she went. Then she went to the health department, and then she became one of the CHWs. And she found her medical background to be very helpful. But unfortunately, where her hands were tied, she goes, I know it, but I can't touch it. I can't touch their meds. I can't do those things.
Yes.
But she knew enough to be frustrated, I think, by it.
Sure. And the nurses have a very clear line that they delineate what community health workers can do and what they can't, because if they can do certain things, then those are reimbursable services. And so we really have to be careful about not crossing that line until legislation says we can. And I don't know that is even necessary. I think that the things that the community health workers do that aren't specifically clinically medical still have so many benefits that they are important enough to be reimbursable, and that's been shown in other states. So other states are actively doing this. This isn't reinventing the wheel. This is just seeing someone else, using a wheel instead of walking. So I think we can recreate that model in Michigan to the for the benefit of all of these communities who need these community health workers and need them now.
Yeah, there's been a lot of things. Michigan is kind of about mid-pack on the community paramedicine side of things, but there are some areas, it's not geographically, it's not states, it's pockets. So again, like Emerging Healthcare Partners, one of the best programs in the state. There's Tandem 365 on the west side. Great, very robust, phenomenal programs. Those are two different. Tandem 365 is more mobile integrated health, where Emerging Healthcare Partners is more community paramedicine. But wow, that's what I wish, that's what I'm hoping we can be when we grow up.
Well, I think Michigan is kind of mid-pack as far as community health workers go. We do not have reimbursable services or state recognition of the certification or a licensure, but some states don't even have a certifying body at all, like MiCHWA. Some states do and some states don't. So we, in that respect, we are, like I said, mid-pack. Because we do have MiCHWA, which is great to offer support and continuing education to the CHWs. Some states have a foundational training, but they don't monitor continuing education. So once you have the foundational training, your training stays the same for the rest of your career. You don't really have opportunities like this to continue to gain training that is really relevant to what you're doing, that helps to inform the scope of your work and improve the lives of the people in the communities you serve. So it was really helpful to learn about what you had to offer, and we thank you for that.
I appreciate it. Like I said, our group was wonderful. We so much enjoyed, our opportunity. So I'm glad I had that opportunity to have the background I did with them. Again, I'm sure every area is a little bit different, just like our community paramedic programs are. But wish you guys all the best of luck. And like I said, I'm hoping within a year we've reorganized things a little bit. I've got it's actually two gals that are our innovation team, kind of new to our group, but one of them is working hard on. We have to do similar things. We compliments of COVID and some of the the CMS rules that were put in place to take care of people in place, and some of the opportunities that happened there, have given us a lot more, I guess, credibility when it comes to, we can do a lot of cool stuff and we can save you a lot of money, but we need to get paid to do it because I can't do it for free. Because we did it for free forever. When I started, I'm on salary. That was absorbed into my cost. I just spent so many hours a week. That's just what I did.
Right.
And we can't do that in a grand scale. So, I'm hoping that we can, again, if we can get the ARPA funds to build put the infrastructure in place. And then what we're hoping for is we already have the folks to talk to. So many of these really strong programs, like you're talking about, using templates from other states, and we're going to do the same thing from other agencies, saying, we want to do what they're doing. You're paying them, just please pay us. It's that simple.
Right.
And so looking forward to it. Looking forward.
We'd love to regroup with you maybe this time next year, and maybe someone from your team or your team, we can do another webinar and see what progress has been made.
Okay. All right. Sounds great. And this has been a pleasure, Portia. Hopefully it come across okay. Hopefully I didn't do too much humming and on and stuttering.
It was great. It was perfect. So thank you for that. You're a natural speaker and it was very easy to listen to. And it was a pleasure having you as a guest. So thank you. We'd love to have you again.
Oh, that'd be my pleasure. Man, I'll tell you what, this is good. Quick sidebar, we had an EMS conference 2-3 weekends ago. And I work closely with state on a lot of different things, and our state director and I are friends, and I sat there and I go, Emily, and she goes, Lynn, in 3 dimensions, it's awesome. We give each other a big hug, because
finally,
yeah, we see each other in Zoom meetings, regularly, but 3 dimensions is way more better.
It definitely is. Hopefully those times will come around again soon. Okay, thanks everyone who stuck on till the very end. I'm going to stop the recording, and thanks once again to Lynn.